Hey guys, welcome back to the channel. Today we are discussing the Cryostat 2 trial, early and empirical high dose of cryoprecipitate for the hemorrhage after the traumatic injury. My name is Dr. Buddhabhushan Borade, MBBS CTCCM. You can follow me on Instagram. My ID is Dr. Bhushan /BBD, and you can follow me on YouTube channel MediTalk by Dr. Bhushan. You can subscribe this channel to get a new trials and PPT.
Disclaimer: the content and information on this video is for education purpose only and is not intended to be recommendation of any kind of sum whatever. Under any circumstances, the author accept no liable for any indirect, incidental, consequential, exemplary damages arises. This video may contain copyright material, the use of which may not have been specifically authorized by copyright owner. This video is available in an effort to advance understanding of educational content.
Clinical question for the study: in a patient with trauma and critical bleeding who require activation of major hemorrhage protocol, does the empirical administration of 3 pools of cryoprecipitate 6-gram fibrogen within a 90 minutes of randomization and no more than 3 hours after injury improve survival and compared to the standard care? Background for this study is a global burden for trauma is huge. With a 4.4 million deaths worldwide per annum, it remains the leading cause of death by young people in RTA. Death often occur early. More than 50% of patients who die do so in the first 4 hours. The most common mechanism of death is hemorrhage, which exacerbated by coagulopathy and fibrinolysis. Fibrogen act as a stabilize the clot formation. Trauma cause activation of coagulation pathways, and fibrogen levels drop by rapidly due to consumption of fibrinolysis and dilution. There is no association between the low fibrogen levels and poor outcome. It is a hypothesis that a cryoprecipitate transfusion may ameliorate this state. The ideal approach to transfusion in traumatic hemorrhage has been extensively studied and refined over the years. The PAMPER trial demonstrated that for a trauma patient at a risk for hemorrhage shock, the administration of thawed plasma during the pre-hospital air medical transport was safe, resulted in lower 30-day mortality. And the Cryostat pilot trial conducted at a 2 UK trauma center show that the administration of a cryoprecipitate 10 unit in addition to empiric massive hemorrhage pack of 6 unit PRBC, 6 units of FFP plus 10 plus minus 10 hexaacid rise in fibrogen level was feasible with a mean time of administration of 60 minutes. Design for the study: this is a multi-center phase 3 international RCT open label parallel groups allocation concealment achieved using the opaque sealed envelopes. The randomization sequence was computer generated with a variable block size and stratified by the center. The waiver of a consent was allowed in order to randomize the patient. Informed consent to continue data collection was obtained from the patient or legally authorized representative as soon as practical possible. The trial was designed to detect 7% absolute mortality difference with a 90% power and 5% level of significance. Sample size of 1600 patients was calculated adjusted after the 4% dropout. Analysis was intention to treat the trial was overseen by the ethics committee and data monitoring committee to review interim data and monitor patient safety. Setting: 26 major trauma centers in UK and USA. Patients were enrolled from August 2017 to November 2021. This is a recently trial published in JAMA. Population for this study: inclusion criteria: trauma with evidence of active hemorrhage requiring activation of the local major hemorrhage protocol MHP. MHP activation at all centers including systolic BP less than 90 mmHg at any point, started or received at least 1 unit of blood component. Exclusion: transfer from another hospital, injuries deemed incompatible with the life of trauma team leader, more than 3 hours elapsed since the time of injury. Participant: 1604 eligible patients, 799 were randomized to cryoprecipitate group and 805 to standard group. 1531 patients in intention to treat analysis due to missing data for 73 patients. Baseline character were all match. Comparing cryoprecipitate group versus standard care: median injury severity, median age 30 versus 40, Median time for injury to emergency department arrival 75 versus 77 minutes. Blood injury, penetrating injury, head injury, pre-hospital tranexamic acid, pre-hospital blood product. Median time to randomization 15 minutes across the both groups. Intervention for the cryoprecipitate group. 3 pools of cryoprecipitate 6 gram fibrinogen given as early as possible, ideally within a 90 minutes after the hospital admission, and MHP as per control group. 85% patient got a cryoprecipitate in the intervention group. The main reason for not receiving it were not evidence the active bleeding. Hemostasis was achieved or the patient died. Median time to cryoprecipitate was 68 minutes. 68% received the first dose within a 90 minutes. Control group, as per local MHP, typically patient were transfused RBC, FFP and platelet in ratio of 1:1:1 with 2 pools of cryoprecipitate with a second and subsequent pack of 4 gram of fibrinogen. 32 patients received cryoprecipitate in a control group. Median time to cryoprecipitate was 120 minutes. 9% received the first dose within a 90 minutes. Management common to both groups. All other therapies were as per local major trauma protocols. Outcome from this study comparing cryoprecipitate with the standard care. Primary outcome, no difference in all cause of mortality at 28 days, 25 versus 26. The pre-protocol analysis also showed no difference. Standard outcome, no difference between group. 6-hour mortality, 24-hour mortality, 6 or 12-month mortality, transfusion requirement, ventilator days, ICU length of stay, hospital length of stay, GEO score at the date 28. Median time to death was 191 minutes in cryoprecipitating group and 86 minutes in control group. Analysis impact of the time cryoprecipitate administration on a 28-day mortality less than 45 minutes, 40 to 60 minutes, 61 to 90 minutes, more than 90 minutes. Predefined subgroups, no difference in result based on sex, age, head injury. Penetrating injury group here worse with a cryoprecipitate 28-day mortality 10% versus 16.2 in standard group. Blunt injury group had a 20-day mortality 30% versus 34 in standard group. Safety, no significant difference in thrombotic events, pulmonary embolism, deep vein thrombosis, myocardial infarction, and stroke. Strength for this study, strong internal validity, allocation consignment, intention to treat analysis, well balanced baseline characteristics, minimal loss of primary analysis, 4.639 patients in cryoprecipitate group and 34 patients in control groups, an important clinical question with outcomes that are clinically meaningful. Patient had a very injury severity score, thus increasing the chance of finding treatment effect. The results are likely applicable to others similar advanced trauma care system. However, this was primarily a trial in UK hospital with 49 USA patients randomized to external applicability outside the UK would need to be assumed cautiously. Weaknesses, unblinded, potential source of bias. There was some crossover between the groups. 15% cryoprecipitate group did not receive any treatment. 9% the control group got early cryoprecipitate within a 90 minutes. This was not deemed to impact the result in the pre-protocol analysis. The intervention was empirical and not tailored to the individual need as such some patient not have had a hypofibrinogenemia. Giving cryoprecipitate in the patient with a normal fibrinogen may be pro-inflammatory and harmful. There is a single to benefit in blunt trauma subgroup, harm in penetrating subgroup. However, there is an inadequate statistical power to interpret these subgroup findings. Author conclusion, early empiric high dose of cryoprecipitate in a patient with hemorrhage following trauma did not reduce 20-day mortality. May I suggest the result from this trial do not support the empirical cryoprecipitate therapy in trauma patient with a major hemorrhage. The hypothesis that there is a gold Goldilocks zone 60 to 90 minutes in which administration of cryoprecipitate may be beneficial is thought to be provoking and warrant further exploration. I will use a road time to guide a product of administration in a bleeding trauma patient. Thank you. Please like, share and comment and then subscribe to my channel.